TS is a 3-week-old male who presented to the emergency room this morning with worsening vomiting over 1 week. He's been vomiting after feeds for 1 week, sometimes right after feeding and sometimes delayed up to 60 minutes. The vomiting has worsened over the course of the week. It's always milk-like in appearance, non-bloody, and non-bilious. Parents report that it can be projectile in nature and often wets their clothes and the baby's clothes. He's continued to gain weight over the past week despite the vomiting. Parents are feeding only breast milk from both the breast and the bottle. They state that keeping the baby upright has not helped to decrease the vomiting. His past medical history: he was born full term via spontaneous vaginal delivery. He's up to date on his immunizations with hepatitis B given at birth. He has no past surgical history, no known allergies, and no current medications. He lives at home with his parents with no siblings. He is breastfed and has so far met normal milestones with no concerns for developmental delay. He has no family history of gastrointestinal issues and no sudden cardiac death, no drownings, and no car accidents. His review of systems was negative except for constitutional. He had no fevers, no lethargy, no irritability, and he's continuing to gain weight despite vomiting. From a respiratory perspective, there's been no difficulty breathing or tachypnea, no cough or congestion. GI is positive for vomiting, but parents deny any episodes of diarrhea. He's been making adequate urine with about 6 to 7 wet diapers a day, and he has no rash. Our last set of vital signs: blood pressure was 80/54 with a heart rate of 159. Temperature was 37.1 degrees Celsius. He was breathing 23 breaths per minute with a oxygen saturation of 99% on room air. His weight upon admission was 4.42 kilos, which is the 50th percentile for his age. My physical assessment: he's alert, well-appearing infant in no apparent distress. His head was normocephalic and fontanelles are soft and flat. His eyes, sclera, were white with no injections. Ears, normal external ears. His neck was supple with no lymphadenopathy. Lungs were clear to auscultation bilaterally. He had no work of breathing. His heart tones were absent of a murmur with a regular rate and rhythm. His abdomen was round, soft, non-tender, non-distended, with no palpable masses. He has normal external genitalia with testicles descended bilaterally. His rectum was patent. He's alert and active with normal tone and moving all extremities equally. He's warm, well perfused with no deformities, and his skin was of normal texture with no rash. Current access is a peripheral IV. Labs: we have a CBC that is pending and a basic metabolic panel that is pending. He did obtain some imaging down in the emergency room, an ultrasound. Findings were an elongation and thickening of the pyloric channel. The pylorus measured 1.8 centimeters in length and the wall measures 0.4 centimeters in the greatest diameter. These findings are consistent with hypertrophic pyloric stenosis. So Theodore is a 3-week-old previously healthy male, born full term, admitted for worsening vomiting over 1 week. His ultrasound was consistent with hypertrophic pyloric stenosis. He is hemodynamically stable and preparing for surgery this afternoon. Other reasons for vomiting may include gastroesophageal reflux or GERD or a milk protein allergy, although these are less likely given an ultrasound consistent with pyloric stenosis. From a plan standpoint. From a neurological perspective, we'll provide comfort as needed. From a respiratory perspective, we'll maintain oxygen saturations greater than 92% on room air. From a cardiovascular perspective, we'll monitor him on 3-lead EKG. FENGI, he'll remain NPO prior to surgery, and we'll initiate IV fluids of dextrose 5 with half normal saline and 20 of potassium chloride at a maintenance rate, and adjust as necessary pending results of his chemistry. Pediatric surgery has been consulted, and they plan to obtain consent for surgery this afternoon.